And when you're using a fine end suction probe, it's a lot narrower, so it's a lot more prone to getting blocked. So quite often the suction probe got blocked just like it did there. I've had to come back out and I've had to clear it. Now we still can't see the eardrum here, and so quite often people ask, how are you able to perform, or are you able to perform endoscopic procedures in narrow ears? Well, this is a great example. It illustrates that you can, and in fact, once you're skilled and have got the appropriate training, it offers you a much better view of this ear. An alternative method of removing this would be to using a speculum, which is kind of almost like an ear funnel. And by using a speculum, it automatically narrows the view. So this ear canal is already narrow, it's already inflamed, and it's going to constrict the view even more. So once you're skilled with an endoscope, there's no ear that you can't actually perform procedures in, and the view it offers, as I said, it's unparalleled. So we're just at the roof of the ear canal here. This is almost like caramel, this consistency. It's very thick, very viscous, and again, it's just blocked with tube. And you can see how inflamed the outer part of the ear canal is. It's really, and the ear canal is quite angry. It's red. You've got all these dry skin flakes, which is very a typical landmark of otitis externa. The patient will, we've written to the patient's GP for them, and they will need some treatment for this, typically antibiotic spray. It can take 7 to 14 days use for it to be effective. Now, we're just directly on the eardrum now. This debris has somewhat crystallised and it's crusted on the eardrum, and I think it's at this point I will remove this. You can just see where to the left, the bottom left of the suction probe, it's a bit darker, and that's where it's kind of crystallised, and I think I worked from that point, and I managed to peel a lot off the eardrum directly. So again, I'm just entering with the endoscope, although the ear is very, very inflamed, very narrow, still be able to get access. And what I'm able to do now, I'm inserting the endoscope past the swelling to keep the canal ajar, keep it open so it won't collapse. So the eardrum is actually behind this debris, this layer of gunk, artery, and there's the bottom part of the eardrum, so that's that crusted dry skin that I was referring to. So at this point already the patient could hear significantly better, but again I want to remove as much debris as possible. So we've got some dead skin here at the bottom, at the base of the ear canal, that I'm gently just peeling up and away. Now, I don't remove every little last flake of dead skin or debris. It's just not humanly possible to do that. We'd be there all day. But I was pretty pleased with what I was able to do. So with these cases, I don't use irrigation or syringing at all. I don't use any water in any of my procedures. Water has got inherent risk. If you're an avid follower, a viewer of my channel, I always advise against allowing water to enter the ear. It can have disastrous effects. You just saw there, I just removed a large piece of dead skin off the posterior